Hello, everyone. Welcome to the 13th week of our weekly briefing on preventing and managing COVID-19 in the workplace. This is Karen O'Hara, Director of Marketing and Communications with WorkCare. We appreciate your continued participation, and we welcome those who are new for the first time to this weekly briefing. This session is being recorded. We upload the recording on our YouTube channel within 24 hours. During the webinar, Alexis will post the link to that site. She'll also post the link to the questions and answers that we summarize at the conclusion of each webinar and post on the WorkCare website. I wanted to just mention that we did a webinar yesterday featuring Dr. Brittany Bussey, a WorkCare Associate Medical Director in our telemedicine division. And she spoke on navigating mental health cross currents as employees return to work. So if you didn't get an opportunity to attend, that is also on our YouTube channel, and Alexis will post the link to that as well. I thought it was really interesting. During the session, please submit your questions using the Q&A function on Zoom. Before we even started today, we got one question, so that's a good sign. Our speaker today is Anthony Harris, MD, MBA, MPH. Dr. Harris is a board-certified occupational medicine physician. He's WorkCare's Chief Innovation Officer and Associate Medical Director for on-site clinical operations. He's also the lead clinician for our COVID-19 response. And now I'll turn it over to him. Dr. Harris?
Excellent. Thank you, Karen, and thanks everyone for joining me once again. And we're going to talk about that four-letter word or acronym, so it speaks, that we mentioned last week. If you weren't with us last week, I'm going to leave you hanging for a couple seconds on that as we get into it. But as usual, we're going to jump right into the topic at hand, updates on COVID-19. So the format, again, not changing today. Clinical update first, and then some of the pathology, microbiology updates. We'll talk about epidemiology, then on to prevention, and then finally workforce strategies for dealing with that four-letter acronym. So in terms of the clinical update, the main thing I want to bring forth today is the study that looks at the number of asymptomatic individuals and transmission of COVID-19 from these asymptomatic individuals. And this study in particular that was published just several days ago estimated that 40 to 45% of infections are occurring as a result of asymptomatic individuals. Okay, and so this is undergirding the evidence that we saw early on in terms of number of asymptomatic people in the general community, and then it goes on to validate those numbers through looking at a broad perspective with studies that have been conducted since April until May. So basically all of April, all of May, this study retrospectively looked at what was published and what those findings were from those publications that they found, and came to this conclusion. So that's useful information for us in regards to, again, understanding how do we best protect our workforce and then obviously the general public as we serve the communities with regard to where the businesses are located. So when we talk about the pathology and microbiology, we want to update real briefly here on the success or not success, failure, if you would, of vaccines. We want to give you a quick update as to where we are with vaccines and the number of studies that we reported on several weeks ago. And if we look at this list of studies, we can see quickly, and if you weren't actually, if we back up a second and you weren't with us a couple sessions ago when we talked about the different phases of FDA approval, clinical approval of a vaccine, there's phase one, there's exploratory, phase one, phase two, and phase three. Okay, and so we looked at how many studies were in a phase 3 circumstance, and there was only one study that was in a phase 2, phase 3. At this point, there are now 2 studies in a phase 2, phase 3 status. One from Oxford University, University of Oxford, and the other from University of Melbourne. And we have a number of studies now in phase 2. That's higher than previously, where we only had 2 studies in phase 2. And the preclinical studies are still numerous, as well as some of the early research studies. But again, we're seeing forward movement in regards to potential vaccines that can come to market and help us with fighting COVID-19. Tony Fauci a week or so ago announced that he feels strongly we'll have a vaccine in the millions potentially manufactured before the end of the year. And certainly, that's the hope that we all hold, but we also realize that manufacturing the vaccine is one thing, distributing it widely logistically is another. And so very likely, even if that reality comes to fruition where we have manufactured vaccines in the millions by the end of the year, it still will be well into 2021 before we have wide distribution of those vaccines. And that's just the nature of the logistics of vaccinating the general population to get to that number where we consider herd immunity effective, which is 60 to 70% of the US population. Okay, and so when we look at then other updates that are important, hydroxychloroquine is probably one of those hot topics that you've heard about with the president and with other individuals that have taken hydroxychloroquine. So where are we at with regard to its effectiveness for treatment of COVID-19? This is a study that the Lancet journal published not too long ago, back in May here on the 22nd, and they subsequently retracted this study. And this study actually did cause some ripples in the clinical community. WHO, as well as several other large-scale studies for hydroxychloroquine, paused their studies because this particular paper came out and suggested that not only did they not find a benefit for treatment of COVID-19 by hydroxychloroquine, there was actually some health risks, particularly cardiac risks, that led to deaths. And just last week, that was challenged, and Lancet ended up retracting this study. So it was mainly, the retraction mainly came around the validity of the data, as well as the conclusion that hydroxychloroquine was causing deaths, and that not being well supported in the data. Yet and still, if we look at other studies, a large study being done in the UK, called the Recovery Study, Randomized Evaluation of COVID-19 Therapy, this study actually stopped its hydroxychloroquine evaluation for all of its patients. And that's just as of June, the 5th of June. And they stopped it because they found no benefit to hydroxychloroquine. And so there are 2 other studies that are pre-publication that also point towards no benefit for hospitalized patients for COVID-19 treatment with hydroxychloroquine. So that's a quick and dirty update in regards to where we stand with potential vaccines and then also hydroxychloroquine. So let's look then now at updating on how we're doing with burden of disease in the US. Last week, we were at 1.8 million cases and 105,000 deaths. We climbed to 1.9 million cases and 110,000 deaths. Okay, we're seeing then when we look at daily new confirmed cases, the U.S., how we're faring with the curve on this 7-day rolling average for COVID-19. Again, this was back on June 3rd as we progress, that was back 2 weeks prior as we progressed to last week, June 3rd, and then finally to this week. We're seeing still flattening of that curve and then some descending slope of this curve as well. Obviously good news in terms of daily confirmed cases. If we look at daily confirmed deaths, we see the curve and the dramatic slope being more prominent here with the bump last week and then trending back down this week in terms of daily new confirmed deaths from COVID-19. This is a new map here for us, and this map looks at where we were back a month ago. with regard to the number of tests conducted in the US and globally, and it allows us to ask the question whether or not those tests and the number thereof, based on the prevalence of illness, were sufficient for fully describing the burden of disease in our population, meaning the U.S. And again, this looks at a global picture of that, because the question has been asked week to week. Hey, we know that where we may be, or another country may be, underreporting the number of positive cases in the population, and that underreporting could be a result of access to testing, right? So this map helps us look and ask that question: is the number of tests available, the methodology for testing at volume, sufficient to suggest either underreporting dramatically, or well approximating what the burden of disease is? And so the red denotes here, and the deeper red denotes here, the number of cases per the number of tests conducted per positive case. Okay, and the way to look at this and interpret it is, if the ratio is low, meaning that it only takes 3 to 5 to 10 tests to discover a positive individual, that's a tight window, right? And that means that potentially you're underreporting the number of people in the population that have positive illness, versus those countries where they're testing in the 100 to 1,000 tests to find one positive case, means that they may be better accurately reporting the burden of disease in that country. So this is where we were a month ago. Here's where we are today. And you can see that we shifted from that 0 to 5 range into the mid zone here, 20 to 40 range. We presented this data in another way in a table form some time ago, and watched that trend in terms of number of tests per positive case. But I think this map better articulates, both in the US and globally, where we stand in terms of accurately reporting the burden of disease in the US. And we're doing better, right? We're not as good as potentially Australia in this case, and some other our neighbors across the pond in Europe, but we're heading in the right direction in terms of getting better at accurately describing the burden of illness. So now let's jump into the prevention, okay? And we talked about last week some of the ways to kind of reshape your thoughts around prevention. We're going to continue that as well briefly here, because we know that determining the necessary level of prevention for your business, for your workforce, is not straightforward, right? If you have a workforce that is in a centralized location in one building, and let's say perhaps that building does not allow for social distancing, that's one particular scenario that may require a level of prevention. From if you have remote workers, right, that are usually not in contact with their cohort. And so we want to make sure you have a good frame for how to process and begin to put in place those strategies for prevention that's appropriate to your goal. And this particular article just highlights what one restaurant in LA has done in terms of screening their patrons as they enter. And we certainly have talked about strategies for patrons in that COVID clear zone philosophy. And so one of the frames that I want to introduce is, we call it ARC in an acronym. It stands for, at the bottom, compliance of the pyramid, the risk, and then assurance strategy, right? So what do we mean by that? Compliance is straightforward. You know, as a business, what state and local laws do we need to be compliant with in regards to how we screen our workforce, and potentially how we screen our patrons if we have patrons that come through the door? Right, and that strategy is pretty straightforward in regards to having to meet what criteria you have to meet to achieve that. The next layer then is risk, understanding the business risks to your operations, and this varies, right? And so if you have a workforce that is highly skilled, right, those workers may not be as easily replaced if they're ill and out, and so you need to have a higher level of protection, or more conservative approach to protecting the business operations with that worker population, right? Another example of that is the work we've done at Work Here and we're doing with production studios and the talent that's in front of the camera, right? You have a major talent in front of the camera that gets ill, it's going to be very difficult, if impossible, to replace that individual. So having a tighter process for prevention is going to be key in those scenarios. And then the top layer of the arc is assurance, right? And this kind of goes and answers another goal of the overall approach to your prevention. You know, and the assurance is, what do I need to do to get the workforce to come back to work? And again, we're seeing this play out as locations reopen and business reopen, that, hey, you can come back to work, but in certain cases, employees don't, because they have anxiety and fears about coming back to work and the environment thereof of having a potential transmission of COVID-19. Likewise, patrons, right? The anxiety of coming into a public space and not patroning certain businesses, we know is happening because there's not a strategy to help protect them potentially, right? And so that assurance philosophy or goal becomes necessary to consider with regard to your overall program and your approach. And then if we expand into kind of the cycle of surveillance, we mentioned COVID surveillance previously. This further extrapolates or breaks down what that philosophy and that approach can represent in your organization. First starts with that arc consideration, right? What are the prevention goals? What do you want to achieve? The next piece of it then, CCA, is the COVID community assessment. And we've talked about this as well in terms of assessing the lay of the land in regards to prevalence or incidence of disease where your business is located, right? That assessment needs to happen because, again, if your incidence and prevalence is low and your overall risk is relatively low, then your approach will be different in terms of its level of conservatism, potentially versus your business that's located in a high-risk area based upon prevalence and incidence. And then the next piece of this is your ops. How are you going to operationalize? So your strategy for operational success is your approach to instituting your program. Is that going to be an in-source program? Can your EHS folk handle that approach in the volumes that they may need to handle it in terms of return to work and screening individuals? Or is that an outsourced strategy in regards to operationalizing your approach to COVID-19? And again, we're talking about this approach being necessary, not just for tomorrow or next week or next month, until we get that vaccine distributed widely in 2021, we'll likely have these strategies in place in your business throughout the rest of this year and beginning of next year. And then the last piece is success metrics, achieved or not, right? Looking at those end goals and ensuring that, yep, we're making progress with the goal we set out to do to begin with, people coming back, anxiety levels are low, or we need to, in turn, change our goals or change our process to maximize our opportunity to keep people safe or to bring people back into the workforce with lower levels of anxiety. So that's, again, a frame for thinking about your program for surveillance for COVID-19. And then finally, the four-letter acronym. I know I've been leaving a number of you hanging if you weren't with us last week, but the four-letter acronym here is OSHA, okay? And it's being a little jocular when I say four-letter acronym or four-letter word, but in essence, what OSHA has said is that employers now must be responsible for investigating whether or not a worker contracted COVID-19 at work. Right, and so this is for all employers, and the only type of employer based upon categories are those that are exempt, are categories of employers that traditionally have not had to report each incident in their 300 log. So if you're a electronics retail store, there's a list of them that OSHA puts forth and they've had for some time. But again, that is for reporting any incidents of COVID transmission. If you're under 10 workers, you don't have to report every incident. You only have to report those that result in COVID-19 infections that result in a hospitalization or loss of life, right? But certainly this is going to apply to many of our employers, certainly in the manufacturing industry, in the power distributing industries, and we want to make sure you have a frame for understanding the causality of COVID and how do we tackle that. And so we'll talk about that frame in a very similar way that we talk about causality analysis in general in occupational health. And that's using what's called Branson criteria. The Branson-Hill criteria are a set of criteria that we can regularly refer to understand the causal nature of a potential exposure at work and the resulting illness or disease. And as we jump into this, we start with kind of the first block that needs to be captured to do this type of analysis, right? So the first piece of it is the history of exposure. So how is the worker exposed to the infected COVID-19 individual in the workplace? And documenting that really well is first and foremost, right? And if there's little data there, then you may not be able to make a causality analysis until that information comes to light. Was it in a closed, confined space? Was it in an opportunity where it was brief in nature? All right, some of those questions need to be answered. And then the established diagnosis. This is a gray area for this type of analysis, right? So we know that there are two types of diagnosis for COVID-19. One, laboratory confirmed, and two, presumptive. And OSHA has not clarified whether or not a causal analysis needs to be done only on laboratory confirmed. So what does that mean? That means if your worker is diagnosed by his or her provider presumptively with COVID-19 and was not tested, that number may be higher than those individuals that actually have access to testing and have laboratory confirmed COVID-19. Just something to document and think about as we anticipate the volume of processing that you may have to do with your worker population. And then the literature review really is referring to, is there documentation out there that either supports that the exposure and the causal illness, in this case obviously COVID-19, likely happened at work or not? All right, are there other situations that are documented, such as the church incident that we mentioned, right? We know that that's a scenario for a super spread. Right, and so if you have a establishment like that, and we know that there's clear linkage between incidents of COVID and exposure in that setting, then that's something to consider here as well. And then we rank the associations on, again, going back to the Bradford-Hill criteria, these are the different levels of associations that we want to consider. And strength of association is specifically referring to what is the significant strength and relative strength of the exposure and the outcome, right? And so again, considering the nature of COVID-19, this is talking about person-to-person spread, right? We're not talking about primarily other types of transmission, although it's still plausible, right, that an individual can have transmission of illness from a surface. Right, that was more prominent early in the history of COVID in terms of research. That's less prominent now, as you all are aware, in terms of latest research. Consistency of the evidence speaks towards what is the consistency that that's available to us for like scenarios, right? Are you working in the meatpacking industry? We know very well that that industry has a higher likelihood of transmission. Are you in a long-term living facility? Again, higher association of COVID-19 transmission in those scenarios. And then specificity of result. This speaks towards maybe perhaps that differential diagnosis of, is it laboratory confirmed or assumption of COVID-19 by a clinician. And we want to make sure that if it's not laboratory confirmed, that we're documenting well what other illnesses it could be, most likely from a non-work related standpoint, but it needs to be considered in terms of evaluating COVID-19. Next is the temporal relationship, right? Was the individual exposed yesterday or last week, right? Or beyond 14 days ago, right? And that obviously plays a significant consideration in whether or not this individual likely contracted at work if the temporal nature of it doesn't match up to what we know to be true in regards to how someone contracts COVID-19 from a person-to-person spread. Next is biological gradient. And this speaks towards, traditionally, this speaks towards the adage that the dose makes the difference, right? And so if we were talking about radon gas, there's a certain threshold of radon gas exposure that can cause cancer in the lungs. And under that exposure level, the likelihood is low. And we're going to make a similar association here in regards to, hey, was the person exposed to the other individual who's COVID positive for less than 10 minutes, for less than half an hour or longer? And were they exposed in, beyond the threshold of that social distancing, right? Was it 3 feet or 6 feet, or was it longer? So documenting that really well and considering that in each exposure scenario is going to be critical because, again, the greater the exposure, whether it's temporal proximity, is going to increase the likelihood for a work-related causal association here. And then coherence is kind of a summary of plausibility of what's available in the research to us, right? And so an example of this would be the surface contact or surface transmission research that has come out and said is not as prominent as we once believed. And so making those considerations, if that was the potential exposure, is important to do when we talk about causal nature. So walking through each one of these is going to be critical for you as you consider causality in the workplace. And certainly, if going back to that previous slide of strategy, if you've decided to outsource your approach to COVID-19 management, this is the process that we use here at WorkCare and certainly are ready to implement on a routine basis. And then the last piece of it is just the opinion that you have to render in order for something to go into your 300 log or not, right? And for us, it makes a difference in terms of probability. That approach doesn't mean that this 100% of the time is not the case, right? Meaning that this person, yes, has COVID-19, and we're saying without absolute doubt that it happened at work. No, we'll never say that. What we are saying is that it's 50% greater that this individual did contact it at work, or it's 50% or less. And that's all you need to do in terms of causality. You need to be 51% in one direction or 51% in the other direction. Making 100% causal association is rarely, if never done in a causal consideration from an OC health standpoint. So I know that was a lot of meat to that topic of causality, a lot to cover in this short amount of time, but we will make these things available to you. We certainly can do so in a consultative manner as well. I'll pause, stop there, and we'll open it up for questions. Thank you.
Thanks, Dr. Harris. Yes, I was just thinking we should develop guidelines on causality subsequent to this webinar based on what you just presented. So you and I should collaborate on that. We've gotten a lot of questions, and we'll try to get through as many as we possibly can in the remaining 10, 15 minutes. A number of people have asked about the data on asymptomatic carriers and the WHO's position on it, and how one of their leaders had stated that asymptomatic carriers it was rare for exposure, but then I read after that announcement that they kind of dialed it back, and she said she was really referring to pre-symptomatic versus asymptomatic, which means the person just hadn't developed their symptoms yet, as opposed to never developing symptoms. So could you clarify the position of WHO in comparison to the data that you just presented on asymptomatic carriers, which shows a significant percentage of cases come from asymptomatic exposures?
Indeed, yes, and what you're referring to did happen just as you articulated. WHO came out and said asymptomatic individuals, and this was in a reporting scenario, if you would, not official research, but in conversation in a report stated that it wasn't as prominent as once believed, which did by again subsequent reporting seem to contradict what we know to be true in the literature, and they did backpedal on that. in regards to clarifying what they actually meant, which was not the full scope of proportionality of asymptomatic transmission. So you're absolutely right. The WHO, since they backpedaled, is not supporting or suggesting that asymptomatic transmission is not prominent or not something that should be dismissed.
Okay, thank you for clarifying that. There's a couple questions about case rates in the United States. One person wants to know what your opinion is regarding the actual number of COVID-19 cases in the U.S. And another person points out that by including New York City data in national data, it possibly skews the results. And if we remove New York City from overall totals, it would be a significantly different picture. What are your thoughts on that?
There would need to be, just as with any study in sampling data, a reason to exclude New York. If that reason is valid, then sure, the numbers would go down. But again, when we talk about looking at transmission of illness, we know that proximity and number of contacts is the primary means for pandemic spread. And so certainly those higher dense areas would likely have higher transmission rates. So with that being said, I can't fathom a scenario in which it would be valid to remove any particular jurisdiction from a articulation of disease in the U.S. And as it pertains to studies that point towards those type of reasons, I'm not familiar with any as of yet.
How comfortable do you feel with the case rates that are being reported? Do you think it's pretty accurate reflection of the current status, or there is underreporting?
Sure, and that was the impetus for presenting this data, as you see on your screen now today, to give us some indication of, are we drastically underreporting, or are we getting better or getting close to accurately reporting the burden of disease? So based upon this data, I would say we're doing okay. There's still room for improvement, obviously, in that we're in the middle of the range of performance with regard to testing to number of positive cases it takes to find a positive case on a 7-day rolling average. So we've certainly improved, and we're doing okay and on our way to do better.
Well, a couple of people have pointed out that Australia and New Zealand, for example, seem to be doing really well and are kind of going back to quote unquote normal. And they want to know, what are they doing differently there than we're doing here?
Sure. So I kind of geeked out on New Zealand in particular, right? And Australia followed suit. They got on top of strong social distancing very early, and they went very hard on the restrictions, meaning that you couldn't even ride your bike by yourself on the streets in New Zealand. And this was back in February of this year, February and early March. So that has been what has been attributed to the success of New Zealand and Australia in their performance with COVID-19. Strong social distancing mandated early on. And now, just recently, New Zealand has reported 0 cases of COVID nationwide.
Okay, now I'm going to read you a couple of scenarios because I think they're instructive. Oh, sorry. I didn't mean to interrupt you. Were you finished with your thought?
No, it was just 0 current cases. Not that they've never had any cases, right? I wanted to clarify.
Okay.
Reported 0 current cases of COVID.
Okay, sorry. Didn't mean to jump in so quickly. There's a couple scenarios from different employers describing their situation, which I think is instructive because it probably pertains to others. The first one is, our business brings on 50 to 70 temp workers during harvest. How do we ensure they don't present a hazard to the permanent workforce? Can we demand that temp agencies do testing for COVID-19?
Sure, that speaks towards kind of what are your obligations, one, as a business, and then what are you legally allowed to do with regard to mandating screening. And what we've seen, and again, this is for sure, I'm not a lawyer, so this is not legal advice, but what we've seen anecdotally with the employers that we work with, anyone who has mandated testing and screening for their workforce has done so across the board. So in that scenario, you would both screen the temp workers via whether it's with the third-party vendor or on your own before, as those workers are selected to come work with your organization. And you would also screen your workforce that are permanent, just so that you're in the clear in regards to what has been done with other employers that has been okay with EEOC and ADA.
Okay, this one has sort of a similar question, but it relates to the customer. We have workers who go out on service calls to homes. What questions should be asked during the phone call from the customer to schedule a service call? Do we need to ask more than if anyone in the house is on isolation for COVID or having flu-like symptoms? That's what OSHA is recommending. Our manager wants to include whether they've traveled outside the country in the past 14 days, specific symptoms for COVID in the past 14 days, any contacts they've had, loss of taste or smell, etc. What are your thoughts? Can we just go with the one question OSHA recommends?
I think that is a risk-based strategy, right? If you're in a high endemic area, you may need to have additional screening questions beyond what OSHA is recommending versus a lower endemic area for COVID-19. And then also that is in regards to the individual that's making the visit, right? If it's a service call that's being made by an individual that may have pre-existing conditions, that puts them in potential harm's way or increase for poor outcome from an exposure and transmission of COVID-19, you may need to ask additional questions for that particular scenario. So doing that risk assessment for your workforce on a both individual and workforce-wide level would be prudent to determine how much screening needs to happen for those particular service call encounters.
Okay, next question is about an interpretation by OSHA. Why does OSHA treat COVID differently at work than they do other diseases like heart disease or cancer?
Meaning cancer from the workplace, if I'm understanding the question correctly. As far as I understand their approach to COVID now, which is different from several weeks ago, where they said they weren't considering it necessarily work-related. It now mirrors more closely the approach they take with, let's say, cancers, right? If you have an environment in the workplace that increases the risk for a cancer, let's say mesothelioma in this case, because your workers are around asbestos, that asbestos surveillance program is required. And so that has been around for decades. And we know now that OSHA is requiring some type of surveillance or some type of evaluation for COVID-19 in a similar way they've required for other diseases such as and illnesses such as mesothelioma. So if something is meant different by that question than how I've interpreted, would love to address that as well in a follow-up.
Okay. Here's a question about the CDC social distancing requirement, where they initially said 10 minutes exposure within 6 feet. And this questioner says they heard that they've changed that to 15 minutes. I haven't heard that, but it might be possible. And they wonder what your thoughts are on the 5-minute difference.
Yeah, so CDC actually didn't have a temporal relationship to close contact definition. They had a distance requirement, and that was 6 feet, but did not introduce temporal requirements, much like or dissimilar to what was done across the pond in other countries, where 15 minutes was used. In some literature, 10 minutes was used. In some jurisdictions, 30 minutes was used. So I am not aware that CDC had introduced, particularly early on, even any temporal requirements for defining close contact. Whether but a 5-minute difference between 10 minutes versus 15 minutes, it again goes back to that notion that I mentioned earlier with regard to gradient, right? What's the biologic gradient for exposure? And that's what that 5-minute difference is trying to get at. Longer exposure means higher rate, potential rate of transmission, and that's, you know, the only real consideration there in terms of difference.
Okay, we have time for just one more question, and those of you whose questions we haven't answered, please check back within a day or so on our website, and we'll have answered all the questions, including the ones that didn't get asked on the call. This is about hydrochloroquine and where it originated. How did and who started or stated that hydrochloroquine is a helpful drug in treatment for COVID?
I don't know. I don't know exactly who was credited with originating hydrochloroquine as a remedy for a treatment for COVID-19. But that's an interesting question, and I'll do some digging and see what we come up with. But I'm not aware of any single attribution at this point.
Okay. Well, we're out of time, so I want to thank you, Dr. Harris, once again for giving a very informative presentation. And I'm looking forward to learning more about the causality analysis as it relates to COVID. And I just want to thank all of our attendees who join us week after week. We really appreciate your participation and interest in this really important topic.
Thank you so much, everyone, for joining, and stay safe as always.
Be well.